Jens Spahn, of course, you know, when he became Federal Minister of Health 2 years ago, then nobody would have thought that he would have so much attention. So he can draw on his long-standing experience of the healthcare speaker of his parliamentary group, and he has also experience in the financing of resilient health system. Then our host, the CEO of the KBV, he is a settled physician, orthopedian, amongst others, and he knows the reality of the practices, and he knows and has a lot of experience, and he knows that it is much better to deal with problems and accept challenges than just sit around moaning all the time. He was recently in China. That was when we heard about the first corona cases. At the beginning of this year, Dr. Doris Pfeiffer, my neighbor, is the president of the Federal Association of Sickness Funds. That's the self-management of the statutory health insurers. And you were very impressed by this, and when you came back from China, you offered a test free of charge. Then Mr. Kluge, are you going to keep your protection? And he is from the World Health Organization, the regional director for Europe. And Dr. Kluge has been working and been committed to the WHO for many years now. He's also a experienced physician. He has a lot of medical experience from his home country, Belgium, and he's also worked for Doctors Without Frontiers. Can you hear me, Dr. Kluge? I have the impression that he cannot hear me. Yes, you can. I'm very happy that you, I see you with your face mask.
Yes, indeed. So I have a mask, first and foremost, out of solidarity.
Oh, I see.
With the member states in Eastern Europe, which have to implement much more restrictive measures. And indeed, we are here with 4 people in the room, so we are walking the talk.
Okay, so we have a very esteemed panel here, and we all have the same purpose to talk about the making health systems more resilient. So please, let's start in to this round with the lessons learned. Minister Spahn, you are the first. Yes. Thank you very much, and good morning, everybody. Thank you very much for organizing this also in the framework of the German presidency. And we could have had a conference that would have been much more widespread without this situation, and but nevertheless I'm very happy that we have the option of doing this virtually, and because it is a pressing matter to talk about this topic internationally. So let's talk about the challenges, and then after that about the lessons that we can already draw in Germany and internationally. First of all, we have tackled this crisis relatively well in Germany, even with all the problems in our everyday life. And until now, I've looked it up just now, no neighboring country of Germany has better infection rates than we have in terms of the general population. So let's be thankful for that, and let's be hopeful that we will be able to get through the next months, and we have the healthcare system by our side because it is very robust, it is very resilient, and it is very good. It does sound very neutral in a way, but we're talking about people. We're talking about hundreds of thousands of people who work everywhere. The physicians, the pharmacists, people who work in the hospital care, everywhere. And we've seen that those professions who were not in the center of attention before, like the assistants in the laboratories, without them, nothing would have worked as well with the testings, with the results, with managing this crisis. And we have these structures all over Germany, and we have an efficiency in these structures, and much better than in other countries. So we did take this make this decision of dealing with the crisis within the self-management, and we also decided that the tests are going to be free of charge. So we have a lab structure which is very tightly knit and is very very professional in comparison to other countries, because we cover all people. So 19 out of 20 people with COVID-19 systems are being treated in an outpatient mode, and so the hospitals are free to deal with hospital cases. And this is the big difference to other countries, to many other countries in Europe, where all these people went to the hospitals. And people got infected in the hospitals as a result of that. So we have this bulwark, this protective wall, which are our medical practices, and it worked very well. It's still working. It's still protecting us from the crisis spinning out of control. Yeah, of course, at the beginning we had some insecurities, and we did have some problems, fever ambulances, for example, or we did see that overall our structures are very strong. So we do have an effective tracking and tracing system. And our task now is to maintain that. So we have several other strengths that I'm not going to mention now in detail. What can we do to become even stronger? On the one hand, digitization and electronic patient files would have helped us, for example. And it would have helped us with the evaluation of the test, Mr. Busse, because there's some time lap. We need to wait until we have some data to be able to evaluate. And this would have helped us. So the electronic patient files will be a reality as of 1st of January. And I'm personally driving this because and we send the message to the health agencies, to the local health agencies. So within 3 or 5 months, we have reached a level of digitization that has been a legal requirement for more than 10 years, and everybody is cooking their own soup, has been cooking their own soups, and now we have digital appointments. People can go to the doctor online. And I was laughed at only a few years ago when I suggested that, because that could decongest the waiting rooms, and it can make life much more easier for those who have to deal with and have to be treated analog and presential in the practices. So digitization and the exchange of data, that's something where we can improve. Then also data sovereignty in Europe. So European health data is a topic that we are driving within the framework of the German presidency. so that we can use data together. We don't need 27 different approaches, because in Germany alone we have several approaches, because every federal state has their own system. So how can we connect each other better in the future? Then just 2 more points before I conclude. Then we need to be less dependent on China and on so it shouldn't be decided in China whether we have enough face masks or effective drugs. So we discussed that, and now in November we are pushing that. We want to start with a new strategy for medications, and now the healthcare professions need to have a different standing. They need to be defined and revised in what they have to do in their content. So it is very outdated in part, and it hasn't been, these descriptions haven't been revised for decades. So we need more professions, and the ones that we already have in the care system need to be defined and updated, and the healthcare professions need to be newly defined and revised. So that's a innovation motor. Mr. Gassen, we've heard a lot. So from the perspective of the KBV, what can you say about the positive conclusions of this crisis? Yes, the minister has mentioned all the topics that should be mentioned, actually. I hope and I think, and I can add on that. Yes, Mr. Busse his presentation was very interesting, and he confirmed something that we had thought before, the conclusions that we've come to before. The only reason we have come through this crisis so much better can only be the system, because everything else we share with our European neighbors. So our healthcare system has saved us of dramatic progressions. And so we have the decentralized system with, at the same time, a very professionalized hospital landscape. So we still sometimes have to transfer people from one hospital to the other, but in general, it has worked very well. So the outpatient treatment of patients in hospitals is not a good solution, and we've seen this in the other countries. In Great Britain, every 8 out of 10 people were infected in the hospital. And a very important point was that we started very early on with the testings for those with statutory health insurance, and this means that we could roll out the testing into the population, and we have very intelligently used the capacities that we have in the testing labs. So we are now in a position where we can control the situation. Now we can do 1.2 million tests per day. And we had 9 to 10% at the beginning of positive results. And we are still testing very generously. And this means that we our data is pretty accurate. So if we have test situations, in Israel, for example, we have 14% of positive test results, and that's dramatic. So we can assume that there are quite a lot of people walking around which are positive and haven't been tested. In Germany, this is not as high. So maybe 2,000 or 3,000. That's a figure that has to be taken seriously, but it doesn't induce us to change the general concept and the general decisions that we've made. So we have seen that we can deal with higher numbers, and I think that we can deal with lower numbers even better now in the future. And I think that gives us the peace of mind that even if we have a higher incidence in the fall now, in the autumn, then we can be confident that our system is going to tackle that. And then we might have some kind of vaccine by the end of the year for a relatively low number of people, of course, but that gives us the peace of mind to see exactly who is going to be vaccinated. Yes, that also leads us in the second round, but let's finish this first round with Ms. Pfeiffer. And the question is, how do you tackle the crisis with your system?
Many of the things that were mentioned by the previous speakers can only be reiterated by me. In many cases, we were lucky, but we also responded quickly. So let me talk about the number of beds that were kept free and the support, the funding support of the government for that. So retrospectively, one could say it was not necessary, but it had the side effect that cannot be appreciated enough, was that people didn't go to hospitals, and thus the infections were prevented. So this was not the intention. The intention was to keep the capacities free, but the side effect was that people refrain from hospitalizations. And this also needs to be taken into account. Funding, the lump sums that were paid for keeping hospital beds free. This was right from the start funded by the federal government. That is to say, most of the costs were funded by the government. That was slightly different for ICU beds. There was a decrease of hospital treatment, which led to a reduced number of expenses. And thus the reimbursements were more or less compensation, which were not necessary for the testing and other measures that were and had to be funded. So, and that is a combination of factors that led to the situation that we did not get into financial difficulties now, and that we are not going to get into financial strains this year. But it's curious to see what will happen next year. So the economic development, the income situation will be crucial, but there will also be further costs once incurring once the hospital treatments will get back to normal. And there's also the question, when will there be a vaccine, and how will the vaccines be funded? And we can expect considerable financial burdens. We try to estimate that, but one knows that such estimates are always difficult to make in Corona times, and twice as difficult. We guess that next year 16 billion will be missing on the budget of the health insurances. And there is the promise of the federal government to, I think you called it the social guarantees. That's to say, There is a limitation of contributions to the health insurance to a maximum of 14%. And here we said these 16 billion should also be paid by federal subsidies. And now there is an agreement with the Minister of Finance that it will only be 5 billion, and 8 billion will come from the reserves of the insurance companies, and that the fees, the contributions of members will be increased by 2%. Well, we do have a different view of how this distribution should look like, but we are still in the process of discussions. That is the current status of the debate, and in the course of legislative proceedings. So we will have need of further discussions. Thank you, Mrs. Pfeiffer. Mr. Kluge, we have already heard 4 diagnoses together with one of Professor Busse, what was good and where there's need of improvement. WHO looks further. Maybe you can give us a sketch of a world after COVID.
Sehr geehrter Minister Jens Spahn, Dr. Gassen, Dr. Pfeiffer.
Mr. Spahn, Dr. Gassen, Mrs. Pfeiffer, it is an honor for me to take part in this prestigious event. And I would like to apologize for speaking English. I do come from Belgium, but my grandfather came from Wilhelmshaven. I myself also worked in the surgical department in the hospital of Wilhelmshaven.
Some lessons from the corona pandemic. In overview, the biggest lesson we learned so far is that international solidarity cannot operate if we do not create the conditions for it. And that means reforms. And reform is often a vague term associated with a never-ending process. But it should not be this time. We will only look after each other if we look critically at ourselves first. In fact, COVID-19 offers us a historical opportunity to pioneer reforms in Europe for the pandemic preparedness and response, so that the people of Europe will never have to face incoherence again across and within countries for travel regulation, quarantine period, testing policies, the wearing of masks, physical distancing, lockdowns, etc. And so that the pandemic fight will not be left to the hospitals only, as the minister was indeed telling very well, but engage people-centered primary healthcare systems and all sectors for better public health. And so that policymakers will not be caught up anymore into a life versus livelihood dilemma, and that the question of access to vaccine will not be driven by national interest only, but by multilateral ones following a logic of needs and a logic of rights. So in my view, reforms in Europe should aim at achieving 3 things. First, pan-European unity, pooling the institutional comparative advantage of WHO Europe and the European Union. Number 2, synergy of public health with policy making. And number 3, a WHO Europe fit for purpose amidst the COVID-19 reality. And I will just give very short point here. The first on pan-regional unity. The issue of vaccines, for example, brings the need for unity to the fore. We relentlessly bridge collaboration between all 53 member states, engaging them to prepare for the vaccine, because the vaccine is one thing, but we are focusing now on what I call end-to-end action. For example, the storage, the distribution, huge logistics. And to strengthen our pan-regional effort, the WHO Europe is engaged now in a complete re-engineering of our institutional collaboration with the European Union system. And I'm very grateful to the European Commissioner, Dr. Kyriakides, who with me signed a joint statement at the Reach Committee 2 weeks ago, going into a historical new partnership to serve the people of the countries we both serve. And we are now working on a similar arrangement with the European Centre of Disease Control to ensure pan-European health security. In brief, WHO Europe will provide influence to the EU by extending it beyond the EU. And I would like to thank Minister Spahn for his leadership in the European Union to strengthen the global governance.
Mr. Kluge, thank you very much. You have already mentioned the motto here, but in the second round of our discussion, I would like to have a look at this theme that a lot of hope is put on the vaccine strategy and medical product strategy. Is it possible to provide enough vaccines? And how about a coordination of that? Well, when it comes to vaccines, as Mr. Kluge just mentioned, it is very important for us as the federal government, as an economically strong country. We want to have vaccines and we want to provide access of our people to these vaccines, but at the same time we want to keep in mind the European and international dimensions, so that if possible for all countries, vaccines will be available. We said at the beginning for Europe, that was the first premise, Germany or France alone, we could conclude contracts. We would find a contract partner such as the US or Great Britain, but we could also do it alone. But from the very outset, we said that is not European thinking, because there are countries which when in doubt, would not be among the first to get vaccines because they are not economically strong enough. They have smaller numbers of inhabitants, and that is why we said when Germany, France, and Netherlands started, we are going to negotiate with on behalf of all 27, those who want to take part, depending on the population. If there are 100 million doses, then they will be distributed according to the size of population. Together with EFTA states, Germany would get 1/5, and that was one approach. And then for COVAX and CEPI, we also wanted to provide support. I also said that we cannot always only support international efforts. I could not really explain to my compatriots that we do support international efforts, but not Germany. It is to say, we do both. At the beginning, also in Germany, there was the debate, should one do fast approvals, phase 2 or 3? And then we said pretty fast no, because this vaccine needs a high degree of trust, because it will be applied to as many people as never before in history. Any vaccine was applied. And therefore, we have to go through phase 3 studies and trials, and there are large-scale phase 3 trials, many thousands of tested people, and therefore we are going to have an approval after phase 3 at the European level. We are not going to exclude countries. And a third premise is that we rather rely on several pillars. One could say at the EU, we have got a contract with AstraZeneca. It's a public one, 300 plus 100 million, 400 million. That's a good basis. One doesn't need that many other contracts. That would be okay if the assumption is right that the vaccine would be approved and that would be equally effective for everybody. But we cannot say that. We have seen AstraZeneca. By the way, this is very normal when you develop a vaccine. It had to pause during the development. But therefore, we said we are going to rely on various teams and mRNA, vector-based and protein-based. And it may be that once all all the things are successful, then in Germany we will have too many vaccines, but then I rather share with other countries. But I do not want to get into a situation that we relied on the wrong side, and therefore, as the EU, we have contracts with 6 to 8 manufacturers, and they are also securitized, and you can distribute that in the Facebook groups and elsewhere. So they said, well, they have decided somewhere in Berlin that there will be an obligation to get vaccinated. No, this will remain voluntary. You clearly said that it will be voluntary. There are many people who say, well, I do want to get vaccinated, but I do not want to be obliged, and that is also important to them. You said probably it would be the biggest vaccination campaign in the world. So, Ms. Gassen, this means a lot of logistical efforts. So we also have the influenza flu in autumn. How do you prepare for that? So I would like to say that it's certainly clever to rely on several manufacturers and to do it in the framework of the EU. And generally, I think it is clever to use it also and do it together in the EU with our own resources for the 500 million people, and we should not rely any longer on equipment and resources from China as elsewhere. So, and we should get also and get back the pharmacy of our own. So, the influenza, that is standard business. The medical practices are prepared for that. It is a repetitive process, and we are always wondering why there are so few people getting vaccinated, even though there are the risk groups. So, like Mr. Spahn, I'm not in favor of the obligation of obliging people to get vaccinated. One should rather convince people to get vaccinated. And therefore, I would rather trust on a European-wide approved vaccine than on a Russian vaccine that might be faster available. Historically, it was a blessing, and it's still shocking to see. If you see polio, there are polio victims. Measles is still a fatal disease. And once we have a COVID vaccine, then it would rather be logical for people to say, okay, I get vaccinated. And in Germany and in Europe, we actually want to act together, and we also want to give things to people which have a certain level of security. It does not only feel good, but it also went through a certain competition, and it has proved successful. So that this statement that once there's a vaccine, it will be safe. We do not yet know which one it is important, but we do not yet know in what way it will be available. If it was a large amount of vaccines that would then have to be filled into small doses, that would mean a lot of logistical efforts. But it could also, it really depends on the way in which the vaccines are available and the fact that in the outpatient centers we can really vaccinate a lot of people is a matter of fact. 25 million people can be vaccinated if necessary. So this is a logistic challenge. Mrs. Pfeiffer, do the statutory health insurance funds pay for that, or are you still in coordination how it can be done? So let me also highlight and emphasize that all of us, we need to have a great interest in finalizing these studies and trials, and not getting into a situation where there is somebody saying, okay, we now have a vaccine, even though it has not yet been validated scientifically. So therefore, I would like to highlight, as there are so many expectations and so high expectations, one should still keep this safety aspect in mind. Logistical efforts. In what form will the vaccine be available? I can remember when there was the swine flu, we also thought about how to organize the vaccination campaign. Should one get into gym halls so that people could be vaccinated? One also had to take precautions against infections. I think here we need to wait and see how things will have to be done. Then another question is, how will it be funded? With the swine flu, the question was how to distribute and how to allocate the costs of supply for Tamiflu, and then it had to be disposed of because it was not used, and there was a partial cost compensation. Only those doses that were vaccinated were reimbursed, and there was also discussion about the fact that this is also public service. Vaccination services are the result of good public service, and therefore it should be financed by taxes. And there have been more and more decisions taken by the legislators that the health insurance funds have to pay for that. And I assume that we are not going to turn back this discussion once these discussions will come up. But we are in agreement about the goal that we want to keep the health insurance stable. So far, it was also responsible for the stabilization of the health service by support measures. But finally, it should not be a situation where the insurance companies get into trouble. So, Mr. Spahn, while I think, and here we are in discussion with the states, federal states, I think we should rather start with vaccination centers, not very big ones, for two reasons. The vaccines will be available. They will have to be transported at temperatures of -20 and 70 degrees Celsius. There will be bigger packages, and then you have a prioritization to take. You can do it in medical practices, but if you need to set priorities first, and therefore we have the Ethics Council and Leopoldina and the Permanent Vaccination Council to develop a trial about that. So there needs to be a prioritization, and I think in December, January, February, March, it will be cold. And rather, you do not do the training for individual doctors, but in groups of 20. But I think there will be a kind of central vaccinations, and when it comes to the sharing of costs, there will be a sharing of costs between health insurances and federal funds and regional, and the vaccines. Here, I rather say we do it. Let's do it from the federal budget, because until we have really split it up by whom it should be paid, and at the end there would be a federal subsidy anyway. Whether I pay it right away from the federal budget or whether I pay subsidies, it is the same thing. That is to say, the federal budget will be responsible for the payment of vaccines, and the rest will be shared between health insurances and the ministry. So prioritization. One needs to be and act in solidarity here. Mr. Kluge, that brings me back to what you started with in your statement. You said an important lecture is that we can only cope with this with this pandemic in a solidarity way. Mr. Spahn said if there are too many vaccine doses left, he would be happy to share them. Probably not with all countries and governments in the world, but it is really a core task of WHO to bring about a globally just distribution of vaccines. How can we manage this?
Yes, absolutely. So I'm very grateful to the many member states who support what we call the COVAX facility. It's the facility, as of today, with the largest portfolio of potential vaccines. And high-income countries can prescribe to it, as well as lower-income countries. My challenge as of today, and that's why prime ministers, presidents keep on calling me, because my region or the 50 member states are the middle-income countries. And I think we have to watch that the middle-income countries are not forgotten, because that happened in previous pandemics. And I always say, no one is safe until everyone is safe. The Balkan, the Eastern Partnership. So it's normal that in any crisis, countries are first looking to themselves. But I always say, if solidarity does not come from the heart, it has to come from the brain, because it's a European value, but it's also essential to push back the pandemic. And I think that we have seen a lot of growth in solidarity since the start of the pandemic. But ultimately, if we speak about solidarity, the biggest solidarity I have seen is at the local communities. People watching elderly people, doing shopping for elderly people, young people volunteering. And I think that Europe has been seeing transformations of society in its history as an example for the world. And we have to capitalize on those solidarity in local communities to build back better in Europe.
Dankeschön.
Thank you very much. So we have a quarter of an hour left. Now I may surprise you, dear audience. I don't know if you've seen that in your chat function. And we have a few journalists here too among the audience. And I would like to open the panel for questions from the audience. So, dear colleagues, are there any questions from you? Everything has been said, so there was a question from the chat. So Ms. Reis-Berkowitz is going to give you her voice. Yes, a question from the chat, Alexander Kortus. He asks, are there new recommendations or information about the influenza vaccine for children? Whether you have to give it a different priority, because usually the recommendation is for people who are older than 60, and would that be an advantage in the context of COVID-19? Yes, this came up because there were recommendations or the desire to vaccinate the whole population with the influenza vaccine, and the thought is that the influenza vaccine helps the immune system to cope with COVID-19. That was the general assumption. So we want to vaccinate risk groups, the elderly, and people in constant contact with influenza patients. And children are not among those. And that in mind, I would not recommend to vaccinate children against influenza. And we still don't know for certain whether the assumption that the influenza vaccine helps with COVID-19 is true or not. Yes. So first of all, we would have to see whether the influenza vaccine is good for children. We have a special vaccine, specially developed for people of 60 plus, and then we have different immune systems according to what age we're in. So that's one thing to consider. The second one would be, we have to be very careful. There is the recommendation of the continued vaccination committee. So if the physician recommends a vaccine, then it is free of charge. And all the large SHIs do take over the cost for the influenza vaccine. So between 70 and 90% of the population can get the flu vaccine free of charge. So if we see, and something that I get really angry about is that even in hospitals, not even the caretakers are getting a vaccine. So if you are a caretaker in the healthcare system, then you should take responsibility and get a vaccine, a flu vaccine. But if the vaccination rate is so low, as a Minister of Public Health, I have an interest in seeing that more people are vaccinated. So if I hear that there is a lack of vaccines, then that's simply not true. We've just started with supplying the vaccines. So if we run out of vaccines by January or come February, then I would be a really happy Minister of Health, and then the flu doesn't stand a chance this season. So let's not tell people don't go and don't vaccinate yourself because you may be part of a risk group. No, I think that we if we achieve 26 million in any group, then that's a big success. There's a question from the colleague, Mr. Spahn and Ms. Pfeiffer. We've just heard that COVID-19 produces costs short term. So do you fear that long term the pandemic will generate costs for the healthcare system, and how do you deal with it? As I just said, this year the situation is stable, but if you look at the next year, then we do expect high costs. We cannot quantify them as yet. Of course, we have the vaccination topic, and we've heard the minister. So the SHIs should not be the only ones to carry those costs. Then the treatment of the COVID-19 patients, I'm fairly optimistic, especially in view of what we've just heard in the keynote speech, especially in terms of the ICU beds. So if we control it properly, then we won't have to have so many people in ICU treatment. So I think we still have to be on guard, but there is reason for hope that we will not have very intensive care cases. And the health insurers, of course, this year are dealing with the saving funds for the different groups, for the facilities, for the care, and that's an area where we hope that come next year we will go back to business as usual in order not to have special costs there. But we will have a problem depending on the economic situation that we will have next year, and the other costs that will result from the legal requirements, and the reserves of the insurers have been reduced drastically. And if I look further into the future, into 22, 23, then there might not be any. So 12 billion euros is nothing, according to your definition. You have 20 billion euros of provisions, and we take 8. So the rest is nothing. It's more than 8, actually, unfortunately, because of the current legal situation. We are reducing our reserves, our provisions. And you have several SHIs who have relatively low provisions and reserves, because that was the the instruction that they received, and I'm sure that that's an issue that we still have to discuss, because we might run into problems, because the insurers can not just out of the blue raise the contributions. So several insurers have a combinations of problems maybe awaiting them in the future, and we will still have to discuss whether this is something that the federal minister of health approves, beyond the question of the reserves. So we have a global economic crisis of a large scale. So we build reserves for crises. So if we cannot use these reserves in this time of crisis, just as we do with other reserves, with other funds, I don't understand that. So if we say, yes, we have higher contributions in several regions than in other regions, so the same applies for the unemployment insurance, because in some regions the unemployment is higher than in others, so there are more funds available in those regions with a lower incidence of unemployment. And so in terms of the provision, I think we have to use them. And a key factor is the economic development, and that's where we have several critical factors here. So we have to have a growth. We have to have the protection of jobs. So then we might have to talk about different things entirely. So from the experience of this pandemic, the conscience or the certainty that a strong and resilient healthcare system gives us the security also for the economic system. We could restart so quickly because we have such a strong healthcare system, and that's why it's worth it. And that's what we have to discuss. Yes. If you want to add something, yes, very briefly, because we have some other questions. Yes, the problem is not that we will have a problem because of the costs that COVID-19 has created in the healthcare system. I think once the dust is settled, we will find out what industries are still standing. And yes, Dr. Pfeiffer is just signaling that she unfortunately needs to go. Thank you very much. And I'm happy that the last question was tailor-made for you, actually. So thank you very much, and have a wonderful rest of the day. So I would suggest, Ms. Reis-Bergowitz is looking at me very intently. She has an interesting question. Maybe we could bundle some questions to find some synergies. Maybe Thomas Wossok, to Dr. Kluge from the WHO.
Learned to balance there too.
To balance care too?
Yeah, the relation between the regular care and the COVID-19 care.
Herr Kluge, eine schöne Frage nach Kopenhagen.
Thank you. I understand it's between the balance of the care for the corona and the other conditions.
Yes.
I think it's a spot on. I call it dual-track health system response, and we are actively advocating for this because we know that, for example, in 68% of our member states, there is a delay in chronic care patients. In some countries, the mortality for breast cancer will increase with 10%, with colon cancer, with 15%, for immunization the same. So we really need to follow this kind of dual-track health system approach, which in fact in any cases comes together at a strong primary healthcare system and essential public health. The key issue for me, when I'm talking daily with Ministers of Health, is to protect our health workforce. They are the heroes, they are my heroes in Europe, but we have to protect them from being burnt out. And that Germany did very well by keeping as much as possible outside the care of the hospitals. But in many countries, there is no Resultskader of healthcare workers. So we really have to take care of the mental health also of the healthcare workers. The mental health will be a flagship area for the years to come. Thank you.
Dankeschön. Liebe Kollegin.
Ja,
It's a different topic. Back to the organization of the facilities, fever facilities for the winter, for example. Are you in contact with the federal states, which had different ideas how to organize that? Mr. Spahn and Mr. Gassen, are you talking with each other about how to organize that, especially now that the winter comes? Yes, basically we need 3 types of facilities. When and where we should put them together it's another question. So facilities so we have the fever facilities. That's not a very good term. So corona facility. So the idea is exactly what was just said. So people with respiratory symptoms should be separated from other patients in order to reduce the risk. So that depends on the regional incidency. If you go to Brandenburg or Mecklenburg-Pomerania, where you have a low incidency and you have a spatial distance because you have a low density of population, then you have your practices and your office hours. So I am doing the marketing for you, actually, for the KBV. So we will direct the patients with respiratory problems to these practices, and in other parts of the country with a higher density of population, then we could set up specific or dedicated facilities. That depends on the organization within the federal states. So the interaction between the health insurers and the state healthcare system, sometimes it is a little difficult, but we are getting there. So we have to separate the supply systems. We did that in February and March already, so it's nothing totally new. We had time to further develop our approach, and we will see more of that in autumn and winter. I've been told that we are already in the autumn. Yes, now is autumn. Yes, we have someone here from the WHO and someone who represents the German EU presidency. So the Finnish presidency had the idea to strengthen the EU within the World Health Organization. That's something that is a topic for you. Just imagine we were in a radio show and you had just a few seconds to talk about how can we strengthen Europe in the WHO. Mr. Kluge. How can we strengthen the role of Europe within the WHO, and this in 15 seconds?
A very important meeting on that one, which in fact Minister Spahn will chair with the EU ministers. I think first and foremost, by the pan-European approach, whether it's pan-European health security or for the Europe is beating cancer plan, we need to look at a pan-European role, and then beyond that one for globally, to set the stage. Second is to strengthen the normative role of WHO. What happened in this crisis, I mean, WHO is often criticized, whether right or wrong, for logistically, administratively being a bit slow. But what is dangerous this time is that there's a lot of critical voices to its scientific integrity. And that's something Europe is really a lighthouse of scientists. I mean, we saw my good friend, Professor Reinhard Busse, many experts in Europe. So to strengthen the normative role of WHO is very important.
Dankeschön. Thank you.
Yes, maybe they are the key ones. Thank you.
Van harte bedankt.
Thank you very much, Mr. Spahn. First of all, now that the USA most likely is leaving the WHO, some people are very critical about that, but I must say that the USA have been a very reliant and very strong partner within the WHO in these last decades. So I am still trying to fight for the USA remaining within the WHO. So we can't say that we want a strong organization, but nobody is paying higher contributions or good contributions at all. So why is the Bill Gates Foundation so strong? So the criticism is always that that's private funding. Why is that? Because the states are not paying enough, and the WHO can only be as good as the data that we provide them with. So and this applies for China. This applies to other countries. So if China doesn't give the data to the WHO, then the WHO can't do anything. It can't send troops anywhere to enforce the agreement. So we need financial means, and we need the cooperation within the organization. So we still can improve, Mr. Kluge, the communication between headquarters at Geneva and the regional offices. So don't you have an appointment tomorrow? I'm not sure about that. Yes, tomorrow. Oh, you got me there. Tomorrow, yes, we have a meeting of the EU presidency with the topic of the WHO. Yes, tomorrow we want to start in November. We want to try to find a common position by November, and tomorrow is the kick-off meeting, let's say, and it's not enough for Germany to agree with all this. We need to get all the other member states of the EU into the discussions and try to find a solution for that. Yes, you know my appointments better than I do. Thank you very much, Mr. Kluge, for being with us, and thank you, both of you. Mr. Gassen, you will remain here for the next panel. Mr. Spahn, my takeaway is we should be humble in spite of our good results and hopeful at the same time. And Mr. Kluge, my takeaway from you is that everybody has to be safe individually for all of us to be safe.